Hello and welcome back to another episode of the PMHNP podcast. I'm Dr. John Rossi with Clarity Education, and today we're stepping into the wide, wonderful world of off-label medications for mental health symptoms. Those sneaky, evidence-based tricks up our sleeves that go beyond the FDA's fine print. So picture this. A patient's symptoms are stubborn, and the standard playbook is coming up short, and you're ready to think outside the box, safely, ethically, and with science on your side. From antipsychotics moonlighting as sleep aids to beta blockers taming stage fright, we're going to unpack the why, the how, and the what to watch out for with off-label medications. All right, so let's go ahead and dive into this topic and see how off-label medication management really helps to transform mental health care. The first thing we're going to start off with are antidepressants with Trazodone. So Trazodone is approved for major depressive disorder, and this serotonin antagonist and reuptake inhibitor, or an SARI, works by blocking the serotonin 5-HT2 alpha receptors and therefore inhibiting serotonin reuptake with a hefty dose of histamine H1 and alpha-1 adrenergic antagonism. At 150 to 600 milligrams, it's a depression buster. But at the 25 to 100 milligram dose, it's a sedative champ. Off-label uses here, we see insomnia and anxiety. So Trazodone helps cut sleep latency by about 10 to 20 minutes and boosts total sleep time in patients with or without depression. We also see that the 50 to 100 milligram dose daily helps tame generalized anxiety, likely via its calming receptor profile. So the mechanisms of action here, we have an H1 receptor blockage that drives sedation. Think antihistamine vibes. Then the 5-HT2 alpha antagonism stabilizes mood and helps curb anxiety. Alpha-1 blockage adds a hypotensive twist, and that's what helps to enhance our drowsy effect. Peak plasma levels hit at about 1 to 2 hours. Half-life for Trazodone is 5 to 9 hours, so it's short enough for bedtime dosing without a groggy next day if it's timed appropriately. It is metabolized by the CYP3-alpha-4, so we do have to watch out for drug-to-drug interactions because it can boost or deplete levels of Trazodone. Now, our patient care instructions, as the PMHNP, we're going to teach them about starting 25 to 50 milligrams about 30 minutes before bed in order to help with insomnia, and then 50 to 100 milligrams split for anxiety. Titrate every 3 to 4 days by 25 milligrams, so slow and steady is going to win here. And then we have to warn our patients about a morning hangover effect, dizziness from orthostasis, and yes, there is the very important education point for men of having a priapism. It's rare, but it's about 1 in 6,000. It's an urgent side effect and has to be addressed immediately. We want to check blood pressure at follow-ups because the alpha-1 effects can drop it. We have to avoid alcohol. It's a sedation multiplier. And then we screen for serotonin syndrome risks when we're taking it with an SSRI or an MAOI. There's no real routine labs here, but if that drowsiness lingers the next day or anxiety persists beyond a 2-week period, we do want to go ahead and reassess dosing and timing. So this is ideal for patients with depression and insomnia or anxiety keeping them up at night. Multitasking at its finest here. Next up, we have Wellbutrin or bupropion. This is approved for depression and smoking cessation. This norepinephrine dopamine reuptake inhibitor, or an NDRI, it helps amp up the dopamine and norepinephrine without touching serotonin. It is activating, not sedating. Perfect for a sluggish, unmotivated, depressed individual. Off-label here, we have ADHD and SSRI-induced sexual dysfunction complications. Bupropion, 150 to 300 milligrams, helps to improve ADHD symptoms in adults. So think better focus and impulse control, matching even methylphenidate in some cases. For sexual dysfunction, we see the 150 to 300 milligram daily dose helps restore libido and orgasm in patients, about 60% of those who are on SSRIs and have this sexual dysfunction complication. So the mechanism of action that we're looking at here with Wellbutrin, it blocks that dopamine and norepinephrine reuptake pumps, boosting the synaptic levels for ADHD and attention, and counteracting those SSRI serotonin driven dampening effects. It also mildly inhibits nicotinic receptors, hence that reason for smoke cessation perks. It peaks in 3 hours with a sustained release or 2 hours immediate release with a 21-hour half-life. It is metabolized by the CYP2 Bravo 6, so carbamazepine can speed it up while fluoxetine slows it down. Now, the patient care instructions that we take a look here, we want to start at the 150 milligram daily dose in the mornings because it's activating, and then titrate to the 300 milligram with a max of 450 milligrams over a 2 to 4 week period. There is a seizure risk here, and it jumps before we hit a high dose of Wellbutrin. And also, if you titrate it too rapidly, about a 0.4% incidence rate. But screen for epilepsy, screen for bulimia, anorexia, and if there's any head trauma first. It is contraindicated in those situations because it will lower the seizure's threshold. We need to warn about insomnia, agitation, headache, and dry mouth. Counsel against caffeine binges or alcohol because both heighten jitteriness. We want to monitor blood pressure. Norepinephrine can help nudge it up. Remember to check seizure history at baseline. Assess ADHD symptoms with scales like the ASRS after 4 weeks, and ask about sexual function improvements. So this really is a go-to for energized depression relief, and if we have any SSRI tank in intimacy. Now, mirtazapine, or what's also known as Remeron, this is approved for depression, and this noradrenergic and specific serotonergic antidepressant, or what's known as an NASSA, blocks alpha-2 autoreceptors to flood the system with norepinephrine and serotonin, plus slamming the histamine H1 for sleep, the sleepiness punch that we're experiencing. Now, off-labelly, we're looking at insomnia, appetite stimulation, and anxiety. 7.5 to 15 milligrams blocks out insomnia in about 80% of patients within a trial. And we see at about 15 to 30 milligrams, we also have this boost of weight gain by 5% in cancer patients and anorexics. So we tie in this 5-HT2C and H1 effects to reduce restlessness and generalized anxiety as well. Now, the alpha-2 blockage ramps up monoamines. H1 antagonism sedates, and 5-HT2 or 3 receptor is going to help tweak and enhance appetite and calm the anxiety. It peaks in about 2 hours with a half-life of 20 to 40 hours, longer in older adults. The CYP2 delta 6 and the CYP3 alpha 4 are going to handle metabolization here. Rifampin can cut levels, and fluvoxamine is known to raise them. So for the patient care instructions, you're going to let them know we start at 7.5 milligrams nightly for sleep and anxiety, 15 milligrams for depression or appetite, maximizing at about a 45 milligram dose. So we are going to expect sedation here. It peaks at lower doses and weight gain up to 2 to 4 pounds in a month. So it's great for underweight patients, tricky for others. Warn about the dry mouth and rare cases of agranulocytosis, about 1 in 1,000. And we do have to check CBC if fever or infection hits in. So no driving if drowsy, and take it 30 minutes before bed. Remember, we have to taper off to avoid any rebound insomnia. Monitoring, we weigh the patient monthly and assess for any sleep logs and watch for neutropenia signs early on in the treatment. So it's gold for frail, sleepless patients needing a mood and calorie boost. All right, so now we're going to jump into amitriptyline or Elavil. This is approved for depression, and it's a tricyclic antidepressant, blocks the serotonin and norepinephrine reuptake with anticholinergic, antihistamine, and sodium channel effects in tow. All right, so off label here, we have chronic pain like fibromyalgia, insomnia, migraine prevention, and anxiety. 25 to 50 milligrams nightly is going to help slash fibromyalgia pain by up to 30% via monoamine boosts and sodium channel stabilization. For migraines, we see at the 10 to 100 milligram helps cut back frequency by 50% in prophylaxis. Insomnia and anxiety, we're looking at hitting the H1 and muscarinic blockage as sleep and calm inducers. Our mechanism of action here, we're looking at peaking in 2 to 4 hours with a half-life of 10 to 28 hours. It accumulates with nightly use. CYP2 delta 6 and the CYP2 Charlie 19 metabolize it. Inhibitors like fluoxetine can spike those levels. So we have to teach our patients. We're going to start at a 10 to 25 milligram nightly, titrating to a 50 to 100 milligram for off-label goals, slowly over weeks. Side effects, there's quite a few here. So we have dry mouth, constipation, urinary retention, and orthostasis, among others. Ringing of the ears can also occur. This is our classic tricyclic baggage that carries with this medication. We do have to screen for cardiac risks. It prolongs the QTC risk above 100 milligrams here. So baseline EKG, if over 40, or if there's any type of heart history. It is contraindicated in narrow angle glaucoma or if the patient has had a recent MI. We have to warn about sedation, bedtime dosing only, and then taper off over a 2 to 4 week period to avoid cholinergic rebound. EKG at baseline, again, for monitoring if dose exceeds the 100 milligrams, and then check pain scales or migraine logs and assess for sleep quality after a 2-week period. So this is a multi-tool for pain, sleep, and psyche. So we have to respect this medication. If we're going to utilize it, you have to monitor your patient closely. All right, so let's shift gears to antipsychotics, the big guns, right, of Psychopharm, with some seriously clever off-label tricks. We're diving first into quetiapine, and then we'll move on to aripiprazole, olanzapine, and then finally risperidone, breaking down the science, their evidence, and how to wield them for these tough case scenarios. For insomnia to OCD, these meds are more than just a schizophrenia fighter. So let's go ahead and dive in here. First, we're looking at quetiapine or Seroquel. This is approved for schizophrenia and bipolar disorder. Now, this atypical antipsychotic is going to block dopamine 2 and serotonin 5-H2A receptors with a hefty antihistamine H1 and alpha-1 adrenergic punch at the lower doses. Off-labelly, insomnia, generalized anxiety disorder, PTSD, and agitation in dementia patients. All right, so 25 to 100 milligrams knocks out insomnia, and that's going to improve sleep efficiency by about 15%. And that's because of the sedative profile. For generalized anxiety, the 50 to 100 milligram daily dose reduces anxiety scores by up to 30%. And PTSD, the 100 to 400 milligrams, are going to result in fewer nightmares and help with hyperarousability. In dementia agitation, we're looking at 25 to 50 milligrams less EPS in older adults on the antipsychotic. Now, our mechanism of action that we're looking at here, we have H1 blockage that sedates, alpha-1 antagonism that calms, and the 5-HT2A or alpha D2 balance tames anxiety and agitation. Now, low doses, D2 affinity minimizes psychosis control, but maximizes the off-label perks that we're looking at today. So it peaks in 1 to 2 hours with a half-life of 6 to 7 hours. It's short-acting unless extended release, and then it's metabolized by the CYP3 alpha 4. Carbamazepine can speed it up, and there's actually multiple medications, but keto can slow it down. Now, for patient education, we're looking at starting that 25 milligram nightly for insomnia, 50 milligrams split for GAD and PTSD, titrating to 150 and 400 milligrams based on response. We have to warn about sedation, orthostasis, and weight gain. There's a 5 to 10 pound rate that's it's not rare, but it can occur. And we have to watch for QTC prolongation. There's a risk above 400 milligrams. We avoid in cardiac arrhythmia history. We want to counsel no alcohol here. It's a drowsiness disaster. And we want to take with food for extended release absorption. We do have to taper off Seroquel to avoid rebound insomnia or agitation. So for monitoring, we're looking at that baseline EKG if the cardiac risk exists, weigh monthly, check for fasting, glucose, lipids every about 6 months, and then metabolic syndromes, a sneaky sidekick here. It can really jump in. So we assess also sleep logs or generalized anxiety scales after about 2 weeks from treatment. So low dose Seroquel is your secret weapon for restless minds and sleepless nights. Next up, we're looking at Abilify. Now, aripiprazole, Abilify, this is approved for schizophrenia, bipolar disorder, and as a depression adjunct. This partial agonist of dopamine D2 and serotonin 5-HT2-1 alpha receptors, plus a 5-HT2 alpha antagonist, stabilizes rather than blocks. Off-label use here, so anxiety disorders, OCD augmentation, and irritability and autism beyond its approved limits. So about 5 to 15 milligrams cuts social anxiety by about 25% via that 5-HT2-1 alpha calming. For OCD, we're looking at 10 to 30 milligrams, boosting SSRI responses, about 50% symptom drop when added. And then autism irritability, 2 to 15 milligrams for a broader behavioral control. Our mechanism of action for Abilify, we have the D2 partial agonism balances dopamine, calming agitation without sedation, while that 5-HT2-1 alpha boosts mood and 5-HT2 alpha curbs obsessive loops. It peaks in 3 to 5 hours with a half-life of about 75 hours, and it stays active days after that dose. CYP2 delta 6 and CYP3 alpha 4 are going to metabolize this drug. So there's poor 2 delta 6 metabolizers need half doses if that patient does not metabolize 2 delta 6 well. Patient care instructions, we start at a 2 to 5 milligram daily, titrating to 10 to 15 milligrams with a max of 30. We warn about akathisia or restlessness, hits about 10% of patients. There's insomnia and nausea early on in the treatment. It's less sedating, so morning dosing works for our patients. And we avoid grapefruit juice. It's a CYP3 alpha 4 inhibition, and screen for gambling or impulsive issues. It's rare, but it can happen. Taper if stopping. Abrupt cuts spike agitation. Monitoring wise, we assess OCD, YBOCS or irritability scales at 4 weeks, and then we check for akathisia weekly at first and monitor BMI. Less weight gain than others, but still is possible. So this is perfect for tweaking SSRI failures or calming kids without knocking them out. Next up, we have olanzapine or Zyprexa. So olanzapine, this is approved for schizophrenia and bipolar disorder. This typically, it blocks the atypical D2, 5-HT2 alpha, histamine H1, and muscarinic receptors. So it does have a broad net. Off-labelly, it treats treatment-resistant depression with fluoxetine, a combination drug there, anxiety and anorexia nervosa with weight gain. The FDA-approved Symbyax, that's that olanzapine and fluoxetine, hints at its depression power, right? But off-label, a 5 to 20 milligram solo or combo cuts resistant depression by 40%. Anxiety, the 2.5 to 10 milligram dose eases GAD. For anorexia, where 5 to 10 milligrams adds about 4 to 6 pounds in an 8-week time period. And that's because it helps with the distorted thinking. Now, our mechanism of action, the 5-HT2 alpha and D2 antagonism lifts mood, H1 sedates anxiety, and the metabolic effects, H1, 5-HT2 Charlie, drive appetite. It peaks in 6 hours with a half-life of 21 to 54 hours, longer in the elderly. The CYP1 alpha 2 handles the metabolization here. Smoking or carbamazepine is going to help speed the clearance with these drugs, so you have to be careful. And finally, we have risperidone or Risperdal. This is approved for schizophrenia, bipolar mania, and autism irritability. Now, this D2 and 5-HT2 alpha antagonist, it really does pack a pretty big punch. Now, the off-label uses are OCD, PTSD, generalized anxiety, and dementia behavioral issues. We're looking at zero point 0.5 to 2 milligram to augment SSRIs and OCD with about a 40% symptom drop. For PTSD, we're going to utilize 1 to 4 milligrams to cut hyperarousal and nightmare symptoms. For generalized anxiety, zero point 0.5 to 1 milligram for mild anxiety relief. And then dementia agitation, this is going to be a 0.25 to 1 milligram, and that should help us see less EPS symptoms than we would with haloperidol. Mechanism of action, D2 blockage is going to calm agitation. And then 5-HT alpha antagonism eases anxiety and obsessive thoughts. It peaks in about 1 to 2 hours with a half-life of 20 hours. CYP2 delta 6 is going to be responsible for the metabolization, but keep in mind, if that patient is a poor metabolizer of it, then they're going to have higher levels in the blood. Moving on to our patient care instructions with this medication, we're going to start with a 0.25 to 5 milligram daily dose, and then we're going to titrate up 1 to 4 milligrams into split doses. You definitely need to warn them about EPS, specifically dystonia and Parkinsonisms. This is going to occur in about 5 to 10% of the patients. Weight gain is a big one here as well, potentially a 5 to 10 weight gain. And then prolactin spikes. So this is where we have a galactorrhea risk. So we need to avoid in Parkinson's and Lewy body dementia cases, EPS is going to worsen with this. So counsel on nighttime dosing for sedation, no abrupt stops, and then helping to remember that we have to taper this over weeks of time. Check prolactin, all right? If amenorrhea or breast changes occur, we need to check it. And then assess for EPS with the AIMS scale. We need to weigh them monthly and track OCD with OCD YBOCS screener. And then also we can track with PTSD screeners and scales as well. So our big pro tip here for the nurse practitioner is this is a precision tool for tough symptoms, all right? We just have to watch the EPS and prolactin. All right, so there's your antipsychotic lineup. Quetiapine for sleep and calm, aripiprazole or Abilify for fine-tuning, olanzapine for depression and weight, and risperidone for all the tough stuff. So evidence-based and NP-ready. So let's go ahead and move on to our next section here, which is going to be the mood stabilizers. These are the unsung heroes in the emotional equilibrium. We're going to dive into lithium, lamotrigine, and valproate or valproic acid. So first up is going to be lithium. It's approved for bipolar disorder, and this elemental wonder really does balance the mood through this symphony of intracellular effects. There's not one single target here. It's just it's a biochemical masterpiece, really. It's quite magical in how it helps with the symptoms that occur in bipolar disorder. So let's talk about those augmentation capabilities here. So this can help treat treatment-resistant depression. This can help treat aggression. And a really good one here is going to be suicidal ideation prevention. All right, so about 600 to 900 milligrams augments those SSRIs, and that's going to help boost response rates by 30% in unipolar depression. For aggression, we're looking at 300 to 600 milligrams to tame outbursts in conduct disorder. And then let's talk about suicidality. Lithium can cut suicide risk by up to 60% across mood disorders. That's unmatched by any other medication. For the mechanism of action here, we're looking at inhibiting the inositol monophosphatase and glycogen synthase kinase 3. This is stabilizing neuronal signaling. It boosts serotonin release for depression and then dampens glutamate for aggression. Multitasking, right, at a cellular level. It peaks in 1 to 3 hours for the immediate release or 4 to 5 hours in the extended release. Our half-life is 18 to 36 hours, longer in renal impairment, and that's another big point to remember. Excreted unchanged by the kidneys, so hydration and sodium levels absolutely matter here. We start at a 300 milligram twice daily, titrating up to the 6 to 1200 milligrams. So we're looking for a serum level here of 0.6 to 1.2 milliequivalents per liter over weeks of time. We have to warn them about excessive thirst, tremors, and GI upset, so early signs of tolerability. Educate on hydration, 2 to 3 liters daily, and stable salt intake. Dehydration or low sodium spike levels is what we're looking for here to avoid. And then we have to avoid certain medications, like, for example, NSAIDs. They cut renal clearance. So watch for toxicity. Lithium toxicity is going to show with confusion, ataxia, seizures whenever the levels in the blood get above 1.5 milliequivalents per liter. And we have to taper lithium off slowly if stopping, okay? Because this can cause rebound mania. As far as monitoring is concerned, we have a baseline renal, we need a thyroid panel, and we should get an EKG for patients over the age of 50 or if they have a history of cardiac issues. We check those levels 5 days after dose changes. And once we get to a stable position, we can then move on to every 3 to 6 months. We're going to do it basically 12 hours post draw or post dosing. Okay, that's when we're going to draw that blood. Now, monitor TSH and calcium yearly. We're looking at hypothyroidism and hypoparathyroidism. We want to prevent those from creeping in. Our pro tip for lithium, this is going to be your go-to for depression with a suicidal edge or aggression that just won't quit. So keep those levels tight. Very, very narrow therapeutic window. Next up is lamotrigine or Lamictal. This is approved for bipolar maintenance and epilepsy. So this anticonvulsant, it stabilizes mood by blocking voltage-gated sodium channels and dialing down glutamate release. Our big off-label uses here are going to be unipolar depression, PTSD, and borderline personality disorder, or BPD. Okay, 100 to 200 milligrams is going to help lift unipolar depression, 50% response rates as a monotherapy approach. For PTSD, a trial of this medication at 50 to 200 milligrams reduces re-experiencing and avoidance issues. As far as borderline personality, 25 to 200 milligrams, this is going to lead to fewer mood swings and impulsivity with the patient. Now, our mechanism here, this is a sodium channel blockage, and that's what helps calm the neuronal firing. So glutamate reduction is going to help curb the excitability. So this is great for depression and that trauma-driven overstimulation. It peaks in 1 to 3 hours. There's a half-life of 25 to 33 hours. This is doubled by valproic acid, halved by carbamazepine because of the CYP induction. These are CYP inducers. It's metabolized in a different way than other medications that we've been talking about. It's not metabolized by the CYP. This is going to be the gluco. I always mess this word up, but it's the glucuronidation. I'm sorry, I'm terrible at this word, but you'll have it there on the screen if you're watching the video. So there are fewer drug interactions. That word gets me every time. Okay, let's go ahead and move on to patient care instructions here. So we start lamotrigine low, 25 milligrams daily for 2 weeks. Then we can go up to that 50 milligram dose for another 2 weeks. We titrate to 100 to 200 milligrams and slower if that patient is on valproic acid. We got to go with a half dose, and that's going to help dodge rash risk. So you got to warn your patients about dizziness, headache, and we have to tell them that about 1 in 1,000 chance of Stevens-Johnson syndrome or SJS risk, it does occur. So we got to stop the medication, and then they need to call if there's a rash or fever. So we educate them on consistency. Missed doses are going to spike seizure risk in epilepsy crossover. So no abrupt stops. We have to taper those over a 2-week period. Monitoring, we're looking at baseline liver function tests, and also we got to check their skin. Watch for rash in the first 8 weeks, especially with the valproic acid or rapid titration of the drug. We're going to utilize the PHQ-9 or the PCL-5 scores to kind of monitor their symptoms over time. And then we want to do that about every 4 to 6 weeks. Our pro tip here is lamotrigine shines for depressive phases or BPD chaos. Gentle but potent if you nail the ramp up. getting it dosed appropriately and within the right time frame is going to save your life with this medication. All right, moving on to our next mood stabilizer, we're going to talk about Depakote. So, Depakote, this is approved for bipolar disorder and epilepsy. This is a broad spectrum anticonvulsant that's going to boost GABA, it's going to block sodium channels, and it tames T type calcium currents. This is a triple threat for stability. Our primary off label uses are going to be for aggression, impulse control disorders, and mood stabilization and personality disorders. So we're looking at about a 500 to 1500 milligram curb for aggression in conduct issues and intermittent explosive disorders, about 60% reduction in those outbursts. For impulse control and any type of similar complication, we're looking to support with 250 to about 1,000 milligrams for emotional dysregulation in any of our cluster B traits. Moving on to how this works. So GABA enhancement sedates. The sodium calcium channel blockage cuts excitability, and this is why it's perfect for aggression and mood liability. Pharmacokinetics here, we peak in 1 to 4 hours with the immediate release, or about 4 to 8 hours if the patient is on that extended release. The half-life is 9 to 16 hours. This drug is metabolized by the CYP2 Charlie 9. Okay, it also uses that other system that I love to say, the glucuronidization, phenytoin, or carbamazepine is going to speed up these processes and will, really eat up and metabolize quicker. So you got to be careful if they're on any of those inducing medications. Okay, patient care instructions here. So we start at 250 milligrams twice daily, and we titrate to 500 from 500 to 1,500 milligrams, and we're looking at serum levels of about 50 to 125. So this is a key point here. For Depakote and for lithium, we have to get laboratory studies. For Lamictal or lamotrigine, you don't. So that's kind of a nice thing for the Lamictal side. So we do need to warn them about sedation with Depakote. There is some weight gain here, about 5 to 15 pounds is quite common. They can also lose their hair. This can be reversible with zinc and selenium. So educate on no alcohol when taking this medication. It amplifies drowsiness. And we have to watch for GI upset with Depakote. So we can use a coated pill to help with that. Avoid in pregnancy because of teratogenicity, those neural tube defects. And then we screen for liver disease. Taper off over weeks in order to avoid any withdrawal seizures. We monitor baseline LFTs, CBC for that thrombocytopenia risk, and we also do a pregnancy test. So check levels every 3 to 5 days after any dose changes. Then we can move on to 3 to 6 months. Monitor LFTs quarterly. First year, hepatic failures are rare, but it is a real risk. So our pro tip here is valproic acid or Depakote, however you want to call it, your aggression and impulse tamer. Broad reach, just mind the labs. All right, so there's your mood disorders. That's our trio of lithium for depression and suicide prevention, lamotrigine for gentle depressive relief, and we're looking at Depakote for aggression and chaos control. Remember, all evidence-backed situations here. So let's ease into some of the anti-anxiety medications now. These are the soothing stars, right, of Psychopharm that calm the storm of anxiety without knocking the patient out cold. So we're going to look at Buspar and hydroxyzine, approved for anxiety, but they're off-label uses. Really, there's a lot of versatility here. Okay, so let's talk about Buspar first. So this is approved for generalized anxiety disorder. It really works as a partial agonist at the serotonin 5-HT21 alpha receptor site and mildly antagonizes dopamine or the D2, calming without sedation or any type of addiction complications. So our big off-label uses here is depression augmentation and also SSRI-induced sexual dysfunction. So 15 to 30 milligrams daily is going to help boost SSRI response in depression, about 40% improvement in HAM-D scores is what we see in the research. Now, for sexual dysfunction, we're looking at 20 to 60 milligrams to help restore the libido and function is going to be improved by about 50%. So sidestepping serotonin's dampening effect of sexual, issues, the libido, that's when we can utilize Boost Bar to help them out. All right, this works with the 5-HT21 alpha, right? This is agonism to reduce anxiety and then lift the mood. So think presynaptic inhibition and postsynaptic calming. Mild D2 antagonism is going to add a subtle mood tweak without psychosis level impact. So there's no GABA action here, no benzo like risks. It peaks in about 1 to 1.5 hours. We'll say half-life is about 2 to 3 hours. So it's pretty short, right? So it's dosed 2 to 3 times daily. This is metabolized by the CYP3 alpha 4. So grapefruit juice. We also see ketoanzolol spikes in levels, and rifampin drops those levels. First pass metabolism means bioavailability is low, about 4%. So timing matters with Boost Bar. We instruct the patient that they're going to start at a 7.5 milligram twice daily dose, and then we titrate that to 15 to 30 milligrams total. So we're looking at a max daily dose of 60 milligrams, and this happens over a 2 to 4 week period. There's a slow build for anxiety or depression effects. We need to warn them about dizziness, headache, and mild nausea. This is early on, and it's transient. So educate your patient about the full benefits taking 2 to 4 weeks. Unlike benzos, which are pretty much immediate, we avoid grapefruit and any big meals. Fat slows absorption. So no abrupt stops here, and then we taper if we're switching to a different medication. Monitor baseline anxiety using the GAD-7. You could use the HAM-A as well, or depression with the PHQ-9. You could use Bex. The HAM-D. There's lots of different ones out there for depression, and reassess at the 4-week period. So no labs are needed unless there's liver disease. If there's liver disease present with Boost Bar, we want to check LFTs. All right, watch for a rare agitation situation and then adjust dose if that agitation pops up. Our pro tip for Boost Bar. Boost Bar is your non-sedating ace in the hole, the big one here for anxious depression or SSRI intimacy woes. Steady and safe. Moving on to hydroxyzine or Vistaril. So this is approved for anxiety and allergic reactions. This first generation antihistamine blocks histamine H1 receptors with a side of muscarinic antagonism. So this sedating and soothing in one situation. Off-labelly, we have insomnia, agitation, and mood disorder augmentation. So 25 to 50 milligrams at bedtime cuts sleep latency by 15 to 20 minutes. That's pretty great. This is going to rival things like Ambien and other hypnotic medications in some cases. So for agitation, we're 50 to 100 milligrams to calm acute agitation in psychiatric settings. What about mood disorders? We're looking at 25 to 50 milligrams as an SSRI adjunct, reducing residual anxiety by up to 30%. Now, H1 blockage sedates. So think allergy, medication, drowsiness dialed up here, while mild anticholinergic effects ease tension and agitation. No GABA or serotonin play here. So it's simple, but it can be very effective for patients. So this is going to peak in about 2 hours with a half-life of 20 to 25 hours, longer in the elderly or anybody with liver disease. It's metabolized by the CYP3 alpha 4 and other pathways. Inhibitors like samantadine is going to boost levels, and then rapid onset makes it great for PRN use. So a lot of times you'll give hydroxyzine or Vistaril as a starting medication while you're getting going on something like Zoloft or Paxil. So that way they get some immediate relief while they're waiting for those medications to build up in the system. Okay, so start at 25 milligrams nightly for insomnia, 20 to 50 milligrams 2 times daily for anxiety, agitation. We're looking at a max milligram a day dose of 100, right? This is, again, for that off-label use. We want to warn about drowsiness, dry mouth, and blurred vision, anticholinergic classics here, and then educate on no driving post-dose and no alcohol. It's a sedation stacker. So avoid in patients that have glaucoma, Uh, BPH or dementia, because of the muscarinic effects, is going to worsen in those patients. Taper is unnecessary. It's not habit forming, but you do want to stop hydroxyzine if there is a QTC risk, if it ever emerges during your treatment. Okay, monitor baseline EKG if there's a cardiac history for that QTC prolongation. Again, it's rare, but it has been reported. Check sedation level and efficacy. So monitor this with sleep logs, agitation scales after about 1 to 2 weeks. So no routine labs unless renal hepatic concerns exist. Then we're gonna get some LFTs and we're gonna check renal capacity. All right, pro tip here: hydroxyzine's your quick, safe fix for sleepiness or agitation. It's old school, but it's golden. Okay, so that's your anti-anxiety duo, the Boost Bar for steady anxiety and SSRI support, hydroxyzine for fast, calm, and sleep. Again, evidence-based, off-label uses. All right, let's go on to some calm with anticonvulsants here. Beyond the mood stabilizers that we previously talked about. So we do have some neuronal tamers like gabapentin or pregabalin and let's see, topiramate. We'll talk about that as well. So these are all approved for seizures and pain, but their off-label reach, it's pretty electrifying, and it's got a lot of stuff that it can do. So first thing we're going to talk about is gabapentin, and this is a very versatile drug. This is also known as Neurontin. So it is approved for seizures or neuropathic pain. Now, this GABA analog doesn't hit GABA receptors, but it binds to voltage-gated calcium channels, alpha 2 delta subunits, dialing down excitatory neurotransmitters. For off label use, we have anxiety disorders like social anxiety, insomnia, bipolar disorder, and alcohol withdrawal. So 300 to 1200 milligrams daily is going to help cut social anxiety by up to 35%, calming without sedation. For insomnia, 300 to 600 milligrams at bedtime to boost sleep efficiency by about 10 to 15%. For the bipolar disorder patients, 600 to 2400 milligrams. This is going to be adjunct for mania or mixed states. Finally, for alcohol withdrawal, 900 to 1800 milligrams to reduce cravings and seizures. The mechanism of action for gabapentin, we're going to have an alpha 2 delta binding, reduces glutamate and norepinephrine release. So quieting hyperexcitability for anxiety, sleep, and withdrawal. There's no direct GABA boost, but it mimics that calming effect. Peaks in 2 to 3 hours. There is a half-life here of about 5 to 7 hours, and it is dosed 2 to 3 times daily. It is poorly absorbed in high doses. All right, bioavailability drops by like 60%, from 60% to 30%. So it is excreted unchanged by kidneys and then adjust in renal impairment. Teach your patients that we're going to start at 100 to 300 milligrams nightly for sleep, 300 milligrams 3 times daily for anxiety or withdrawal, titrating to an 1800, even up to 3600 milligrams, which is going to be your max. So we do need to warn about sedation, dizziness, and peripheral edema. 10 to 20% get puffy ankles. So we want to educate them on no abrupt stopping here. Taper over a week to avoid rebound anxiety or seizures. We need to avoid antacids within 2 hours, so they block absorption. So again, gabapentin, we need to avoid antacids within 2 hours because of blockage of the absorption. Monitor for misuse. It is a controlled substance in some states. All right, monitor baseline creatinine clearance, dose adjust if below 60 milliliters, and then check with GAD-7 scores or PSQI scores after about 2 to 4 weeks. We need to watch for euphoria or dependence signs whenever we have an at-risk type patient. So our pro tip here for gabapentin, this is your multi-tool for anxiousness, sleepiness, or withdrawing patients. Gentle, but watch the kidneys. Next up, we have Lyrica. This is approved for neuropathic pain, fibromyalgia, and generalized anxiety in some countries. Now, this gabapentinoid, it also binds alpha 2 delta on calcium channels, but it's more potent and predictable than others. So off-labelly, we have social anxiety disorder, PTSD, and insomnia. Around 150 to 300 milligrams daily reduces social anxiety scores by up to 40%. So it's faster than SSRIs in many cases. For PTSD, 200 to 600 milligrams is going to ease hyperarousal and nightmares. And for insomnia, we're using 75 to 300 milligrams at bedtime to improve sleep continuity. This is going to be improved by about 20%. So our mechanisms here that are going, we got stronger alpha 2 delta binding. It's going to cut glutamate and substance P release. And so that's what's soothing the anxiety. It's the trauma responses are decreased and sleep disruptions with that GABA-like vibe. Peaks in 1 to 2 hours. The half-life is 6 to 7 hours, and it's dosed twice daily. So we do have linear absorption here, 90% bioavailability. It is excreted renally, so dial down in kidney disease complications. We start at a 75 milligram twice daily for anxiety, PTSD, and then 75 to 150 milligrams, as it were, nightly for sleep, and then titrating to 300 or 600 milligrams, which is going to be your max over time. So warn them about dizziness, somnolence in about 20 to 30% of the cases, and weight gain. About a 3 to 5 pound weight gain really isn't that rare. Educate on no alcohol. It amplifies the drowsiness, and taper over a week to avoid those withdrawal symptoms. We're going to see something like sweats or insomnia set in. Controlled substance in some situations, so we do need to screen for any misuse history that may exist. All right, so let's go ahead and monitor the baseline creatinine clearance, reduce if below 60 milligram minimum a minute, and then assess PCL5 or sleep logs at 2 to 4 weeks, and then monitor BMI quarterly. We need to watch for euphoria or dependence cues. So our pro tip here for Lyrica is it sharpens gabapentin cousin. It's the sharpening gabapentin cousin. Really, there's this fast relief for trauma or restless at night. All right, let's move on to Topamax. So Topamax, this is approved for seizures and migraine prevention. It's an anticonvulsant. It hits multiple targets like sodium channels, GABA enhancement, and glutamate, AMPA, kainate receptor antagonism. Off-label use is going to be bipolar disorder, PTSD, binge eating disorder, and alcohol dependence. Okay, so 100 to 200 milligrams stabilizes bipolar mood, 40% response in mixed states. PTSD, 50 to 200 milligrams to reduce intrusive thoughts. And then we see binge eating, 100 to 400 milligrams is going to help cut episodes by 50%. Alcohol dependence, 200 milligrams. This is going to lead to about 50% fewer drinking days. How does this work? Sodium channel blockage and GABA boost are going to calm excitability. Glutamate antagonism is going to help curb those cravings and trauma loops. And then a triple mood, food, booze fix. All right. Peaks in 2 to 4 hours with a half-life of 19 to 23 hours. So once or twice daily dosing here. 70% renal excreted. It is a CYP3 alpha 4 minimally involved metabolism, so it does have fewer drug-to-drug interactions. All right, so in practice here, we start at 25 milligrams nightly, and we titrate by 25 to 50 milligrams weekly to a 100 to 400 milligram in split doses. So we do need to warn them about cognitive dulling. So that it's what's known as the Topamax fog. This occurs in about 10 to 15%. We also see tingling or paresthesia and a rare kidney stone in about 1 to 2% of patients. We need to educate them on hydration, 2 liters daily to help cut stone release, and no alcohol for dependence use. Taper off over a 2 to 4 week period. Seizure risk spikes if that is stopped cold turkey. Monitor baseline creatinine clearance and bicarb. We watch for metabolic acidosis. It's rare below 17 milliequivalents per liter. And we assess binge logs or the audit scores at 4 weeks. Check cognition if that fog complaint arises. So Topamax is your quirky fix for binges, PTSD, or drinking. Just prep them for the brain haze. Okay, and those are your anticonvulsant trios. So we have gabapentin for broad calmness, we have Lyrica for potent relief, and we have Topamax for cravings and chaos. Okay, let's amp things up here as we continue with our multiple and many off-label use medications. We're going to talk about stimulants now. These are your turbochargers. We get what we call our Zoomers right here for the methylphenidate, modafinil. This is approved for focus and wakefulness. So let's talk about these off-label powers here. So first up, we have methylphenidate. This is known as Ritalin or Concerta. It is approved for ADHD and narcolepsy. This classic stimulant is going to block dopamine and norepinephrine reuptake, firing up the prefrontal cortex for focus and alertness. Off-label uses, we treat treatment-resistant depression and fatigue and chronic illness, something like cancer. We can treat with that. We look at 10 to 40 milligrams daily boosts with SSRI response and depression. So we're going to give this with that SSRI. 50% improvement in HAM-D scores has been noted in studies within about 2 weeks of augmentation treatment. Now, for cancer fatigue, we're looking at 18 to about 54 milligrams with Concerta. That's going to cut exhaustion down by 30% in palliative settings, and that's going to outpace any placebo that we've seen. It inhibits dopamine and norepinephrine transporters, so boosting synaptic levels. It sharpens attention in ADHD, it lifts mood and depression, and it fights fatigue by countering hypoactivity. Peaks in about 1 to 2 hours for the immediate release for Ritalin, or 6 to 8 hours in the extended release Concerta. Half-life is 2 to 3 hours for IR, or 3 to 4 hours in ER. Metabolized by the carboxylase 1 excreted renally and minimal CYP interactions. Again, I am terrible at some of these words. Just roll with it. Sorry about that. Patient care instructions. We start at 5 to 10 milligrams twice daily IR or 18 milligrams daily ER and titrate to 40 to 60 milligrams with a max 72 milligrams for off-label use. We do need to warn our patients about insomnia, appetite loss in about 10 to 20% of cases, and also jitteriness, so early and dose dependent. Educate on morning doses. We want to avoid late dodge sleep disruption. So if you give it late, it's going to really disrupt their sleep patterns later on, and parents are not going to be happy. And no caffeine overload, okay? It stacks the buzz. Controlled substance here, we got to screen for misuse history and then taper off if stopping, because we can see some rebound fatigue at that tapering if we go too quickly. We monitor baseline blood pressure and heart rate. Tachycardia is common above the 40 milligram dose, and then we check PHQ-9 or fatigue scales like the FACT-F at 2 to 4 weeks. We do need to monitor weight monthly because appetite suppression is real. If you're giving this to kids, you definitely need to make sure that you're monitoring their growth charts because it can stunt growth. Okay, pro tip, methylphenidate's a quick lift for depressed or fatigued patients. Just keep the reins on misuse. Okay, let's move on to modafinil. This is approved for narcolepsy and sleep apnea. Actually, you know what? Let's go to, I think we're going to go to propranolol is what I have next on my screens here. Yeah, let's do propranolol first. Propranolol, this is going to be a non-selective beta blocker. It's approved for hypertension, angina, and arrhythmias. It shuts down beta-1 and beta-2 adrenergic receptors, and that's going to blunt the body's fight or flight adrenaline rush. Off-label use is performance anxiety like public speaking or PTSD to help reduce hyperarousal and aggression. 20 to 40 milligrams taken 1 hour before a speech cuts physical symptoms like racing heart and shaky hands by up to 50%. If the patient takes it about an hour before the speech. Okay. All right. For PTSD, 40 to 120 milligrams daily is going to reduce hyperarousal and physiologic reactivity to trauma cues. About 30% drop in the CAPS scores. Aggression, we got about 40 to 80 milligrams is going to help tame outbursts and traumatic brain injury and conduct disorders as well. So our mechanism of action here is that we are blocking beta 1, the heart, and beta 2, lungs, and the periphery receptors. And this is going to slash sympathetic output. So it lowers the heart rate, it lowers blood pressure, and lowers tremors. There's no direct brain action here, but it dampens the body's stress feedback loop to the amygdala, and that's what's going to help ease the anxiety and the aggression. It peaks in 1 to 4 hours, and with the immediate release, half-life of 3 to 6 hours. It is dosed 2 to 3 times daily as needed. It is metabolized by the CYP2 delta 6 and the 1 alpha 2. So fluoxetine or smoking can tweak levels. It is lipophilic, so it crosses the blood-brain barrier, and this adds to mild central calming effects. Patient education, we need to let them know this is going to be for performance anxiety. To give them 20 to 40 milligrams, 60 minutes to the pre-event, single dose, no titration here. For PTSD or aggression, we start at 10 to 20 milligrams twice daily, titrating to 40 and 120 milligrams. Our max is going to be 320 milligrams. Warn about fatigue, bradycardia, so heart rate below 50, and cold hands because of the beta 2 effects. Educate the patient on no abrupt stops. Rebound hypertension is a risk here, so taper over 1 to 2 weeks if they're chronic. Avoid in asthma or COPD patients because of bronchospasms, and check pulse before the PRN dose. Monitor baseline blood pressure and heart rate. Hold if systolic below 90 or if the heart rate is below 50. For chronic use, the EKG if cardiac history exists, and reassess the PCL5 for PTSD or aggression logs at 2 to 4 weeks. So no labs unless there's some renal hepatic disease issues going on. If there are, we'll go ahead and check creatinine clearance and LFTs. So propranolol is your body-based calmer for stage fright, PTSD jitters, or angry flares. So it's fast physical relief without sedation. All right. So let's go on to our soothers here. We're going to talk about clonidine. So clonidine, this is approved for hypertension. It's an alpha-2 adrenergic agonist. It dials down sympathetic outflow, and that's why it calms the body's stress engine. It is used for off-label PTSD nightmares, ADHD, anxiety, and opioid withdrawal. 0.1 to 0.3 milligrams at bedtime is going to help cut the PTSD nightmare frequency by about 40% in some patients. For ADHD, 0.1 to 0.4 milligrams daily is going to help boost focus, about 60% response as an adjunct. And for anxiety, 0.1 to 0.2 is going to show for mild relief. Finally, we have opioid withdrawal, so 0.1 to 0.3 milligrams 3 times daily to reduce cravings and sweats. Alpha-2 agonism is what's happening here. So that alpha-2 agonism in the locus coeruleus cuts norepinephrine. That's going to tame the hyperarousal, impulsivity, and withdrawal shakes. Peaks in 3 to 5 hours with a half-life of 12 to 16 hours. It is dosed 2 to 3 times daily, or it can also be nightly. 50% renal excreted, so metabolized minimally. So we do have to adjust if the patient has kidney disease. Educate those patients that we're going to start on a 0.1 milligram nightly for PTSD or twice daily for ADHD or withdrawal. We titrate 0.3 to 0.4 milligrams with a max 0.6 milligram for off-label use. Warn them about sedation, dry mouth, and hypotension. Blood pressure can dip super fast with this one, so be careful. Educate on no abrupt stops because of rebound hypertension, and taper over 4 to 7 days. We want to avoid in bradycardia. So any patient with a heart rate below 50, we're going to avoid this medication. Obviously, we monitor baseline blood pressure and heart rate. We need to hold it if systolic is below 90. We can use the PCL5 for PTSD or the ADHD RS at weeks 2 to 4. And we also can monitor withdrawal symptoms during daily detox if that's occurring. So clonidine is your multitasker for nightmares, fidgety kids, or detox jitters. Calm and steady. Next up, we have prazosin. So this is a great medication. It is approved for hypertension. It's an alpha-1 adrenergic antagonist, and it relaxes blood vessels, but it really does shine in the brain for trauma-related complications. Off-label use here is going to be PTSD, nightmares, and sleep disturbances. So we're looking at about a 2 to 1 milligram nightly dose is going to help slash nightmare frequency by about 50%. I would say it's maybe even higher than that. And it also helps improve sleep quality. So it's stronger than placebo across the trials that were looked at. Alpha 1 blockage in the brain reduces norepinephrine-driven hyperarousal. We're talking norepinephrine. That's if you get a question about dreams, norepinephrine is going to be the one you're going to be looking for in those answers. It's also muting trauma replay during the REM sleep. It peaks in 1 to 3 hours with a half-life of 2 to 3 hours. So nightly dosing fits the punch here. It's metabolized by the 1-alpha-2 and 3-alpha-4. So smoking or fluoxetine does tweak those levels. We're going to instruct them to start at a 1 milligram nightly dose, and then we titrate 2 to 10 milligrams with a max of 15 for off-label over weeks. Warn them about orthostasis, the first dose, faint risk, and dizziness. They got to take it at bedtime. Educate the patient that hydration is important. Low blood pressure loves fluids, right? So no sudden stops. Taper if chronic, and avoid in hypotension history. So we monitor baseline blood pressures, hold if systolic is below 90, and check sleep logs or PCL5 nightmare subscale at 2 to 4 weeks. Pro tip is prazosin is your PTSD sleep savior. Nightmare kryptonite with a gentle touch. Now on to one of my favorite topics, ketamine treatment and ketamine therapy. So ketamine, it's approved for anesthesia, right? It's an NMDA receptor antagonist, and it really is rewriting the psychiatric rules for off-label use. For off-label use, we have treatment-resistant depression, suicidal ideation, and PTSD. I've also seen it a lot lately for treatment-resistant anxiety. So it lifts depression by 70% of resistant cases within about 24 hours. There is an FDA-approved version of this. So let's talk about the IV first. It's going to be 0.5 milligrams per kilogram IV over a 40-minute time frame. Okay. The FDA-approved version of this, because the IV is not FDA-approved, is S-ketamine. This is one that's going to be taken up into the body by nasal spray. So suicidal ideation, we're looking at a single dose cutting risk by up to 50% within a 72-hour time period. And for PTSD, again, 0.5 milligrams kilogram IV to reduce symptoms. This is under investigation a lot right now, but it is very promising. So how does this work? What's going on with ketamine? So IV peaks instantly, has a half-life of 2 to 3 hours. Intranasal peaks in 20 to 30 minutes. It is metabolized by the 2-bravo-6. It has fast clearance, and it is very short-acting. Education for patients is going to be very important with ketamine treatment. We're going to let them know, again, 0.5 milligrams kilogram per kilogram IV in the clinic, or S-ketamine nasal per protocol, whatever the protocol is in your clinic. Usually it's going to be coming in, administering, and sitting around for about 2 hours for observation. Single or repeated doses can occur. Warn them about disassociation. Blood pressure spikes, about 20 mmHg is common, and nausea. So it's transient, but it can be trippy. Educate on supervised use only. There is no home dosing here as far as we're concerned, and no driving post-dose. It's contraindicated in psychosis or uncontrolled hypertension. We monitor baseline blood pressure and mental status. Monitor disassociation with the CADSS and the PHQ-9 during and after infusion, and then follow up within a 24-hour time period. So, NP pro tip, ketamine's your crisis buster for depression and suicide. It's fast, fierce, and supervised. Next up, we have naltrexone. This is approved for opioid and alcohol dependence. This opioid receptor antagonist blocks reward pathways. So off-label use, self-injurious behavior, binge eating disorder, and dissociative symptoms. 50 milligrams daily is going to cut self-harm urges by about 40% in BPD patients. For binge eating, 25 to 50 milligrams reduces by up to 50%. Disassociation, low dose here, 25 milligrams, is going to help ease the depersonalization. Mechanism of action are those mu opioid blockage, dull the reward-driven behaviors. So this is going to help decrease self-harm, binging, and disassociation escape. It peaks in 1 hour with a half-life of 4 to 13 hours. The active metabolite, the 6-beta naltrexol, extends this, and it's metabolized by non-CYP pathways. So there are very few interactions for naltrexone. We start at a 25 milligram daily dose, titrating to 50 milligrams with a max 100 milligram for off-label use. We need to warn about nausea, headache, and rare liver enzyme bumps. Educate on no opioids, blocks pain relief, and test with naloxone challenge if opioid history is unclear. No taper needed for this drug. Monitor baseline LFTs, repeat if the dose exceeds 50 milligrams, and then check binge logs or disassociation scales like the DES at 4 weeks. Pro tip, naltrexone's your reward rewire for cutters and bingers. Simply put, it's a simple but sneaky, effective drug that we can utilize. Next up, we have, and finally, we have Namenda. So this is approved for Alzheimer's. It's an NMDA antagonist that calms glutamate without ketamine's kick. Off-label for OCD, ADHD, anxiety disorders, and depression. It's a lot of uses. 10 to 20 milligrams cuts OCD symptoms by about 30% as an adjunct treatment. For ADHD, 10 milligrams can improve attention in adults. Anxiety, 5 to 20 milligrams for mild relief. And then depression, 10 to 20 milligrams for a boosting mood. So we have a low affinity for NMDA blockage to reduce excitotoxicity, easing this obsessive loop and boosting focus and then softening that anxiety. It peaks in 3 to 7 hours with a half-life of 6 to 80 hours once daily dosing. It is renally excreted, so adjust if we have kidney disease. Now we want to start at 5 milligrams daily, teach the patient about titration by 5 milligrams weekly to 10 to 20 milligrams. We need to warn about dizziness and confusion. About 10% of patients will become confused. And there is rare occurrences of agitation. Educate the patient on slow ramp up. Cut the side effects down by doing that. And no alcohol here. It muddles cognition. Avoid in any severe renal failure. So anything with a creatinine clearance below 30. So obviously we want to get a baseline creatinine clearance to reduce if below 50 milliliters. Check OCD YBOCS scales or the PHQ-9 at 4 to 6 weeks and make adjustments as needed. And then also make sure you're watching for that cognitive shift. So Namenda is your glutamate tamer for OCD or scattered minds. Slow burn, big potential. All right, and so those are really your big miscellaneous drugs that are out there. Clonidine for nightmares and withdrawal, prazosin for PTSD, sleep, ketamine for rapid depression rescue, naltrexone for reward-driven chaos, and Namenda for obsessive or foggy brains. One that I don't have on slides, if you're if you're watching this, excuse me for not having it up on the screen, but I do want to talk about modafinil real quick. So this is approved for narcolepsy, sleep apnea, and shift work sleep disorder. Wakefulness agent is the type of mechanism. It isn't fully cracked. We don't really understand, but it boosts dopamine via transporter inhibition. And it does hint of some histamine activation here. So off-label use for this medication is going to be depression augmentation, ADHD and fatigue, and multiple sclerosis or MS. So 100 to 200 milligrams daily is going to help enhance the SSRI effects, 40% response rate in treatment-resistant depression. For ADHD, we show about a 200 milligram improvement. If we take 200 milligrams, there's some improved focus in adults, though it is less than stimulants, okay? MS fatigue, we're looking at 200 milligrams to achieve a 25% boost per patient reporting as far as their energy levels. So dopamine reuptake inhibition is going to perk cognition, histamine tweaks wakefulness, And Oroxin hints at sustained alertness, so less jittery than any type of classic stimulant that a patient could use. This medication does peak in 2 to 4 hours, and we have a half-life of 12 to 15 hours. So once daily dosing works really well here. It is metabolized partially by the 3-alpha-4. So watch out for grapefruit juice boost because of the levels that it can increase. And rifampin is going to cut them. There is 60% renal excretion here. Educate the patient on a 100 milligrams starting in the mornings with titration to 200 milligrams with a max of 400. We need to warn about headaches in about 20% of patients, nausea, and rarely we do see insomnia. It is less than methylphenidate. So educate on early dosing. You want to give it by noon to avoid night wakefulness and absolutely no alcohol. This is going to help muddy the efficacy of the drug, so no alcohol here. It is a controlled substance. We assess misuse risk, and then taper is unnecessary in this situation, but it does smooth fatigue rebound. Monitor baseline LFTs and blood pressures. There are some mild elevations possible. We check ADHD-RS or fatigue severity scale at about 2 to 4 weeks, and we also need to watch for a rash. It's rare, but Stevens-Johnson's syndrome is a risk in about 1 in 10,000. So pro tip here for modafinil is going to be a subtle energizer for depression or MS fatigue, clean lift, low crash. Okay, so we'll put that in, that we'll branch that with the stimulants, but it is it's readily available. It's a great medication that could also be utilized for treatment. All right, so that's really it. That's a lot of medications to talk about. There's a lot of stuff to go over. I know this is a long one, so split it up if you need to. I'm also going to try to put a document in the student portal for those of you that are students in Clarity Education and PMHNPtesting.com that you'll be able to have a visual tool to also utilize this if you're not as much as an auditory person and you want to visually see it. So there you have it. Okay. This is our journey through the off-label universe. It's complete, from antidepressants to those miscellaneous marvels that we just talked about. You really do have a lot of science and evidence to back up these practical know-hows for mental health, tough challenges, things that just aren't cutting it by the gold standard or the first-line treatments. So we have to augment a little bit. Okay. So we have a lot of great evidence. A lot of strength that comes up here. All of this information was obtained from journals that utilized RCTs, meta-analyses, and just the higher tier of research. So what I want you to make sure that you understand is, as you utilize these off-label use medications, is you definitely have to educate your patient. They need to know that it is not FDA approved, that there's evidence that backs it, and they need to know the risks, the benefits, and if there are any alternatives that may be FDA approved. And then give them the opportunity to say, yes, I want to use it, or no, I don't. And you need to clearly chart that in your paperwork, that you let them know that it's FDA non-approved, and that the patient gave permission to utilize it, and that all those side effects, adverse reactions, and possibilities have been discussed with the patient. All right, remember, you're not just prescribing here, you're pioneering. You're balancing innovation with responsibility. Okay, use this off-label toolkit to transform those lives of the patients that you're treating, one evidence-based choice at a time. So go slow here. This is PMHNPtesting.com, also Clarity Education Systems. I'm Dr. John Rossi. Here are a list of your references that we utilized during today's session, and we will see you in the next deep dive podcast. Thanks so much. Bye-bye.